Patricio Lancelotti will present the assessment of primary mitral regurgitation in a patient with degenerative mitral valve disease. He will first present the main important features at the level of the morphology of the valve using multiple views. Then he will move to how to quantitate the severity of mitral regurgitation with the different methods available. And finally, the consequences on the left ventricle and the left atrium.
So during the next few minutes, I will show you the key features that should be recorded in a patient with a primary mitral regurgitation related to degenerative mitral regurg. So we will start first by assessing the mitral valve morphology. After that, we will evaluate the severity of the mitral regurg. And finally, we will assess the consequences of the mitral regurg on the left ventricle. Let us start first with the mitral valve morphology. And here we can see a parasternal long axis view. And I will show you all the views that you need to acquire to assess the mitral valve morphology. First of all, as you know, we have two mitral valve leaflets, the anterior leaflet and the posterior leaflet, and here we have the mitral annulus. In that region, we can see the posterior mitral annulus. And the first thing that we have to analyze here is the mobility of the mitral leaflet to see if there is any intrinsic mitral leaflet dysfunctions related to the degenerative mitral valve disease. And to evaluate the presence of a mitral valve prolapse, the analysis of the mitral valve should show an excessive motion of the mitral leaflet towards the left atrium. And typically in this kind of patients, the mitral leaflet coaptation point is in systole below the mitral annulus plane. So this is a typical feature of mitral valve prolapse that we have in these patients with a portion, or even in this kind, a large portion of the anterior leaflet and the posterior leaflet sagging into the left atrium in systole, and this is the definition of the mitral valve prolapse. But be careful. For the diagnosis of mitral valve prolapse, you should use the parasternal long axis view just related to the saddle shape of the mitral annulus. Don't try to use the apical four-chamber view to make the diagnosis, because you will have some valve positive in this situation. So for sure, during the examination of the mitral valve morphology, you should also be able to determine the likelihood of mitral valve repair. And there are several criteria to be analyzed. So first, if there is some redundancy, if there are calcifications, and what scallops are involved in the disease process. And in this situation, both leaflets are involved in the disease process. The mitral annulus is dilated, and we will measure it. And also here you can see a calcification of the posterior wall, and also at the level of the posterior mitral annulus. So this means that this calcification may in some patients preclude the repair of the mitral valve. So the next step for sure would be to see, the LVOT, and we need to measure the LVOT diameter, and we need to assess the cardiac output. But let me just focus on the mitral valve for this examination. And as you can see with my hand, I have just shifted a bit or tilted a bit the probe toward the tricuspid annulus, and it's difficult to be stable. And what we can see in this situation is mainly the examination of A1 ear and P1 ear. And this is just in case you want also to see if there is any important prolapse of the P1 and A1. But in these patients, it is obvious that it is a Ballot disease with an extensive mitral valve prolapse. The other way to analyze, it's a A3, P3, and for that you need to tilt the probe toward the internal commissure, and in that situation you can sometimes distinguish perfectly A1 and P1, but in this situation it's a bit difficult to get these images. So let me now move to the apical view, and I will show you the apical view in this patient. I will just need a bit of gel. Perfect. So in this situation, I will show you here the apical four-chamber view. And with this apical four-chamber view, again, you need to assess the excessive motion of the mitral leaflet, touching here both leaflets. And you see also an extensive calcification of the mitral annulus at the level of the posterior mitral annulus that will also affect the likelihood of mitral valve repair. And you need to also evaluate the redundancy of the mitral leaflet, and the redundancy is defined when the mitral leaflet in diastole is greater than 5 mm, as you can see in these patients with a thickened mitral valve leaflet. So, when we have assessed the four-chamber view, we should turn a bit the probe to be able to see the two-chamber view. And with the two-chamber view, you will do the same exercise. Again, you will analyze the mitral leaflet, and here again you have a bright signal related to the calcification of the mitral annulus. You should be able to see if there is or not some ruptured codae that are often present in patients with degenerative mitral valve disease, and in this situation we have a prolapse that is clearly touching both leaflets. And finally, we will tilt again the probe a bit toward the internal commissure, and here you can see A2P2 and again this calcification of the posterior annulus, but also extending on the left ventricular wall. So just to summarize, if I've turned back to the four-chamber view, just to say that what is important to know about the repairability is first the mitral annulus diameter, and I will measure this in a minute. Secondly is the scallop that are involved, and in these patients both leaflets are involved in the disease process. And finally the redundancy, and we have seen that we have redundant tissue, but also the calcification and the extent of calcification, and we have some extensive calcification of the posterior mitral annulus also extending to the lateral wall, which will be associated with a high risk of failure of mitral valve repair in these patients. So the likelihood of repair is very low. So now let us focus on the different imaging to assess the severity of the mitral regurgitation, and I will start first by the parasternal long axis view, and I will change the position of the probe. So I will go again at the parasternal long axis view, and I switch on the color Doppler. First, I will try to see if there is any regurgitation at the level of the aortic valve, which is not the case in these patients. And after that, I will focus on the mitral valve. And here you can see the mitral regurgitation. And in this situation, it is very difficult to assess the severity of the mitral regurg using the parasternal long axis view, because we have this turbulent jet into the left atrium. But we can probably, by zooming a bit the situation, we can here see a sort of convergence zone, a sort of contraction of the regurgitant jet, and here a sort of extension of the jet into the left atrium. But for sure, we cannot use the parasternal long axis view to quantitate the severity of mitral regurg, so we cannot use the vena contracta, and this is the incidence recommended to assess the vena contracta in patients with mitral regurg. So now again I will change and I will go to the apical view, showing you exactly what we have with the four-chamber view, and here you have a beautiful jet that is related to the regurgitation, and clearly you can see here the convergence zone, the constriction of the flow, and the extension of the flow into the left atrium. For sure, if you want to analyze the color flow mapping here and evaluating the regurgitant jet area, it will be very difficult. It is a turbulent jet, and we know all the limitation of the regurgitant jet area related to the technical and physical factors, and this is the reason why the color flow Doppler is just used in this situation to see the mitral regurg, but not to quantitate the mitral regurg. We should use more quantitative parameters, and the apical 4-chamber view is the recommended approach to use the PISA method. And what are the steps to analyze the PISA method? First, the apical 4-chamber view, switch on the color Doppler, optimize the gain, zoom the selected image, and after that you will decrease the zero baseline progressively to obtain an hemispheric PISA. You will freeze the image toward the cinelope, and you will try to get the best frame with the largest diameter to be measured for the quantification of the mitral regurgitation. And I will try to have this beautiful image for you where we can see here the PISA to be measured. And what we do in practice, we just focus on the regurgitant orifice that is at the base here of the PISA or the convergence zone, and we will measure the distance between this part and the first aliasing that is here, the switch between the yellow color here and the blue color. And in these patients, you can see the measurement that I have done, and here you have almost 1 centimeter. So this means that the radius is high for the aliasing velocity. So what will be the next step to assess the severity of the mitral regurg? The first thing would be, of course, we need to measure the PISA radius. But be sure that the flow convergence zone is constant throughout the systole. And for doing that, what you just need the color M mode across or through the convergence zone. And here you have during the systole the regurgitant flow in M mode, and you can see that the flow is constant throughout the systole. And in this kind of patients, what you have to take care is the late enhancement of the flow, which is in these patients not really seen, except maybe in this part where you see that there is a difference between the beginning of the systole until the end of the systole. So for the next measurement to quantitate the regurgitation, what you need to record using the continuous wave Doppler the regurgitant jet, and you need to measure the peak velocity and the time velocity integral. And with the method, the machine automatically will provide the measurement of the effective regurgitant orifice that is 38 millimeters square. And in this situation, 38 is almost close to 40. So we can say that we have moderate severe mitral regurgitation according to the effective regurgitant orifice. And you know that the cutoff is 40. Below 40, between 20 and 40 is considered as moderate. But in mitral regurg and in primary, we can use two different cutoffs in the moderate part, the mild to moderate and the moderate to severe. And in these patients, we have moderate to severe mitral regurgitation. So now, what are the next steps that we could do in the patients with a mitral regurgitation to assess again the severity of the mitral regurgitation? I will switch on the Doppler to analyze the mitral inflow. And here you have the mitral inflow in these patients. And just we need to measure the VTI. And we have the VTI. We have also the velocity. And you know when the E velocity is written 1.5, this is in favor of severe mitral regurgitation. It's a semi-quantitative signs or parameters. But in this situation, we have 1.2, again in favor of moderate to severe mitral regurgitation. But importantly, what we can assess is the time velocity integral, and you have the measurement that is here. Why? Because we will compare this with the time velocity integral of the LVOT flow. And let me check to have the LVOT flow now. And here you have the LVOT flow, and we will measure the time velocity integral, and we have here the measurement of the time velocity integral. So meaning when we do the ratio of the mitral TVI and LVOT TVI, we have more than 1.4. That is in favor of severe mitral regurgitation. So now let me finish these presentations with the important part, that is the assessment of the consequences on the left ventricle. So for doing so, I will again start by the parasternal long axis view, and I have acquired this image. Maybe I can also try to have this image in my thumbnail. Let me see. Yes, I have this image. So I will just measure the left ventricular end diastolic and end systolic diameter. And you have here the measurement of the left ventricular end diastolic diameter. And here you have the measurement of the left ventricular end systolic diameter. And you know here we have 40 millimeter. So this means that in practice, we have a cutoff value that is close to what the American guidelines suggest as a criteria to be maybe referred for mitral valve repair, when there is a possibility of repair that is almost 90%, which is not the case in these patients. So what we have here is a cutoff that is less to 45 millimeter. That is the cutoff value suggested by the European guidelines. So this means that according to the European guidelines, we can still follow these patients just clinically and echocardiographically every 6 months. So now, of course, we cannot assess the left ventricular consequences just by analyzing the diameter. Obviously, the diameter are always related to the remodeling process, but the main important thing is to measure the left ventricular ejection fraction, because the ejection fraction is clearly a class 1 indication when it is below 60% of evaluation. And for that, what it is recommended is to use the biapical modified Simpson method. And here you have your apical views that we have acquired, and here we have the measurement. And when we use the 4-chamber view, we need also to use the 2-chamber view. And with the 2-chamber view, you can see that the biplane ejection fraction is 62%, meaning that we are still in the good normal range of ejection fraction in this kind of patients. But to be honest, I would have expected to have at least 70%, because 62% in presence of mitral regurg is maybe already a sign of some degree of LV dysfunction. So now, just to show you the measurement of the mitral annulus diameter, which is very important in these patients, I will try to pick up the images regarding the parasternal long axis view and show you how to measure these parameters. So let me try to take the image that we recorded regarding the parasternal long axis view. And here you have your parasternal long axis view. And what you need to do is just the measurement. For doing the measurement, what you just need here to have the length of the anterior leaflet in diastole, and you can measure here the length of the anterior leaflet, and you have to compare this length to the mitral annulus and take care of this calcification. This is a calcification that is at 2 levels, so the annulus but also the ventricle, and you can see here the clear junction of the mitral annulus that is here, and clearly the mitral annulus is dilated 52 millimeter, and if you have the ratio of 52 above 43, you have almost 1.2, 1.3, and the cutoff to define severe or to define dilatation of the mitral annulus is 1.3. So here we have another sign that is in favor of a failure of mitral valve repair, is a severe enlargement of the left atrium when it is bigger than 50 millimeter with a central jet plus more than 3 scallops involved in the process. These are all signs in favor of a failure of the mitral valve repair. So now let me move to the last part of this presentation regarding the consequences of the mitral regurgitation on the left atrium. And here we can have the measurement of the left atrium, the volume using again the Simpson method. We have a volume more than 128 milliliter, and we should index this value for sure in these patients. And when we calculate, the indexed value is greater than 40 milliliter per meter square. This means that is a severe dilatation. This means that when we have a cutoff greater than 40, is associated with some morbidity. And if it is more than 60 milliliter per meter square, is associated with the occurrence also of cardiac death. So, and finally, to assess the consequences, because if we think about any kind of surgery, for sure we need to have the measurement of the tricuspid dimension, annulus dimension, and we should to see if there is any tricuspid regurgitation. And again, I will try to get the image from the apical four-chamber view. And here you have the color Doppler, and you have the tricuspid annulus and the tricuspid valve, and there is no significant regurgitation here. And I will try just to measure that if there is any kind, because even if you don't have any color flow, you should try with the Doppler signal to get any regurgitation that you have missed with the color flow to have an idea of the transtricuspid pressure gradient. And clearly in the patient, it's impossible to get this information. So the last thing to do is to measure the tricuspid annulus diameter. And we will do this. And for sure, what is important to mention is for this tricuspid annulus diameter, whatever the degree of regurgitation, when it is greater than 40 millimeter or greater than 21 per meter square, this is a class 2A indication of tricuspid valve repair when there is a surgery of the mitral valve. So this brings me to the end of my presentation. When you want to assess a patient with degenerative mitral regurg, so primary mitral regurg, so intrinsic mitral leaflet disease, you need first to evaluate the morphology of the valve, which belongs to the qualitative assessment. You need to assess the semi-quantitative parameters, and in these parameters you have some of the parameters related to the severity of the mitral regurg. So quantify the mitral regurgitation. And finally, using efforts should be made always to quantitate, giving some numbers. But efforts should also be made to have an integrative approach of all these parameters. And finally, try to evaluate the consequences on the left ventricle. Thank you. Good luck with it.
So the main points regarding this presentation is that we have not only to assess the morphology of the valve, but also to look at the reparability of the valve. And finally, to use an integrative approach to quantify the severity of mitral regurgitation.